ladies and gentlemen. So, to really understand the importance to make an early diagnosis and to apply a T2T, a treating to target strategy, in IBD, we should first understand why we should treat IBD patients as the earliest as possible. Indeed, we know now that Crohn's disease and also ulcerative colitis are chronic and progressive disease. Unfortunately, all the current available indexes we have only assess inflammatory activity. It could be clinical inflammatory activity, endoscopical inflammatory activity, or biological inflammatory activity. But all these indexes could be equivalent in a patient with a very early Crohn's disease and in a patient with an old disease. And we definitely need to have new instruments to catch the progression of the disease and to catch damage progression along the accumulation of structuring lesions, penetrating lesions, and also surgery. And the consequences of that is that we also need new tools to assess the progression of disability and the alteration of quality of life. That's why the first IBD Disability Index has been developed and recently validated. And that's also why we have developed the first digestive damage index in CD, named the Lehman Index. To assess digestive damage in the whole digestive tract, we have divided the whole digestive tract in 4 organs: the upper tract, the small bowel, the colon and the rectum, and finally the anus. And each organ has been divided in several segments. And on each segment, we have searched the presence and the severity of structuring lesions, of penetrating lesions, and on previous surgery. And we have showed in this first study that clearly damage increased with disease duration, with very lower level of Lehman index in patients with early disease, meaning with a diagnosis within the 2 first years, compared to patients with old disease. And that's very important because that's clear that there is, at the beginning of the history of IBD, a window of opportunity in which we have to identify patients to introduce an intensive treatment to prevent and avoid damage progression and disability progression. So clearly, there is a gap just after diagnosis in which we can stop the progression of the disease. Moreover, some data strongly suggest that anti-TNF treatment are probably more efficient in early IBD patients. Regarding CD and the results of the CHARM study, we know that adalimumab is clearly more efficient than placebo in all CD patients. But regarding the rate of clinical remission, the best results were obtained with adalimumab in patients with early Crohn's disease. And these results have been confirmed in this very recent South Korean study, comparing patients who received early anti-TNF and/or early immunosuppressant treatment compared to patients who received late therapy. And in this study, authors reported that patients who receive early immunomodulators and/or early biologic had significantly less intestinal surgery and a better outcomes regarding disease progression, with less rates of structuring complications and less rates of penetrating complications. Concerning damage, we have recently performed in Lille a prospective study assessing the Lehman index in 130 CD patients. And first, we confirmed that damage clearly increased with disease duration. But we also showed that patients receiving early anti-TNF treatment had lower level of Lehman index, low level of damage, compared to patients who receive late anti-TNF treatment. So there is data that strongly suggests that early introduction of anti-TNF could prevent damage progression and could maybe change the natural history of CD and maybe of IBD. But we definitely need modification disease trial to show if it's clear or not that this early intervention can change the natural history of the disease. And the first disease modification trial is currently processed in dedicated centers. Its name is CURE, for changing the course of Crohn's disease with early use of adalimumab. And there is two main goals in the study. First, to assess if an early initiation of adalimumab could decrease bowel damage, disability, and surgery 5 years after diagnosis, and also if this early initiation of adalimumab could allow us, physicians, to decrease or even to stop as soon as possible the treatment in case of deep remission in order to avoid adverse events at long term and to reduce healthcare costs. So probably we need to introduce early intensive treatments in some IBD patients. But it doesn't mean that we should apply this strategy in all IBD patients. That's why we need to stratify patients for a personalized therapeutic strategy in CD and in UC. And we definitely have to make the difference at an early stage of a disease between patients with indolent disease who don't deserve an aggressive strategy and patients with an early aggressive disease who clearly deserve to receive an early intensive therapy to avoid complications. And if we only take into account the Paris definition, for instance, of early CD, it defines early CD by a disease duration for less than 18 months in a patient who didn't receive any immunomodulators or any biologics. And if we only take this definition to introduce intensive treatment, there is, of course, a high risk of overtreating a significant number of patients. So we need to perform prospective cohort to identify early predictors of aggressive IBD to introduce intensive treatment in a subgroup of patients with early aggressive disease. And for this, we should focus on this study, the RISK cohort, which is an inception cohort study involving at least 1,000 pediatric early Crohn's disease patients. And in this study, authors clearly reported that there was an allele gene signature associated with development of disease complications, but also biological marker associated to the risk of developing structuring lesions and also penetrating lesions, such as the positivity of CBR1. So we need to perform the same study in adult CD in order to clearly identify clinical, biological, and probably genetic factor for early aggressive disease. But awaiting for the results of this study identifying predictors of aggressive disease, we need from now to modify our strategies and to probably apply the treat-to-target strategy. The T2T concept is very simple in IBD. When you introduce a treatment, you need to define a target. It could be a clinical target, a biological target, or an endoscopical target, or even a composite target. And if this target is not reached, you clearly need to intensify the treatment or to switch the treatment in order to get these targets. And if you will look at the IBD T2T recommendation in CD, you can see that this target is clearly a composite endpoint associating clinical remission, patient-related outcome remission, and also endoscopic remission. And it's the same for the recommendation in UC concerning the T2T, a composite endpoint with clinical and PRO remission and endoscopic remission. And now we need to start and to design study comparing a conventional management to a T2T strategy in order to see if applying the T2T strategy could prevent the progression of the disease. And it's the case of the REACT-2 study, which is currently in process, that compares in different centers a conventional strategy, a step-up strategy, with an accelerated step-up strategy based on the results of the ileocoloscopy. And what is very important in this study is that the primary endpoint is the risk of CD-related complication at 1 year. And the definition of CD-related complications include CD-related hospitalization and the occurrence of bowel damage. So we can see with this study if a T2T strategy can reduce the risk of hospitalization and can reduce the risk of occurrence of bowel damage lesions. But again, the T2T is not a global concept. It should be a tailored and personalized approach to each patient. And of course, the target should be very different in patients with early IBD and in patients with late IBD. In an early stage of the disease, we need to have the absence of symptoms, no disease progression, no complications, no disability, and a normal quality of life. In case of a patient with a late disease, the aim is probably to stabilize the symptoms, to avoid the progression of the damage and to prevent the progression of disability and to improve quality of life. At the end, yes, it's very important to make an early diagnosis and to apply a T2T strategy in IBD if we want to change the natural history to prevent intestinal damage and to prevent disability. And for this, early therapeutic intervention and the T2T strategies are key goals to achieve better long-term outcomes in IBD. But again, treatment target should be personalized, should be adapted to an individualized monitoring plan, and in early disease, we should select the best candidates for an early therapeutic intervention in order to attain deep remission, to avoid disease progression, to avoid complication, and to avoid disability. In case of late stage of disease, we need to stabilize the symptom to avoid the progression of damage and disability and to improve quality of life. Thank you for your attention.
A few questions now before the general discussion at the end. This is a very nice concept. I will now tell about the reality, especially in the US, what I'm seeing. You know, very often we see patients who are not diagnosed, maybe they have symptoms for more than 2 years before being diagnosed. Second, there is this study presented by Corey-Siegel at ECHO 2017, showing that 70% of patients are started either on 5-AZA or steroids, and actually the penetration of biologics after 3 to 5 years is less than 5%. Mm-hmm. So it's very nice to be here on stage and to talk about that. How do you think we can improve this access? You know, how we can improve so that we will have access to patients early and not miss this window of opportunity? Do you have some initiative to propose?
From right now is difficult, but we need to have studies showing that this strategy is better regarding, the rate of complications and so on. If this result will provide, we could have, strong data to convince patients to apply this strategy. But today, probably the aim is to explain to the patient that it's a personalized strategy, and the aim is not to treat them with a very strong treatment for all the life, but it is a window of opportunity to treat the patient in order to stop or at least to decrease the treatment as soon as possible. And I think that we should really insist on this point with these patients in order that they understand that the aim is to get a deep remission as soon as possible to avoid, sustained treatment. And I think we should focus on this point.
Yeah.
Yeah, well, I wanted to add that maybe not only in the US, but there was a survey by AbbVie about how long patients had symptoms before the diagnosis of Crohn's disease was made. And like 20 or 25% of the patients had symptoms for more than 3 or 4 years before they were diagnosed with inflammatory bowel disease. And then the investigators in Milan found out that the majority of those patients already had irreversible damage on their MRI scan. Mm-hmm. So I think if we can win somewhere, there's the greatest benefit, the greatest gain is probably to be made in earlier diagnosis. Now, that is a challenge. And I think it has to do with awareness. And IOIBD is investigating a strategy, what we call the Red Flags Initiative, led by Silvio Danese. And it's a very simple tool. It's only 8 or 10 questions, and you have a positive answer to 4 of them. You should have some investigation to rule out Crohn's disease. It's like, do you have a family history? Do you have joint pain? Do you have diarrhea once in a while? Red blood, very simple things. What's your body weight? And so if that questionnaire would be implemented, and we're now validating that in the GP setting, general practitioners, so if that, once that is validating, we can, and EFCA can, as a patient association, distribute that throughout Europe, maybe also in the US, and really increase awareness, because that's really where we lose our patients to surgery and to all those problems because of late diagnosis. How many patients do not present with a perianal abscess as the first presentation? Still common.